everyone, and welcome to our lesson on cardiopulmonary arrest in the emergency department. This is going to be a short lesson, as I'm sure you guys all know how to do CPR by now. We just want to go over what happens in the ED setting. Things are a little different in the ED. The fact is, we never work alone. We know the members of our team, and we all know what our job is. When we do it right, really good things can happen for our patients. So the basics are still the basics. We love our algorithms in the ED. They lay out exactly how to treat our patients. For these guys, you want to remember your BLS and ACLS algorithms. The basics still apply even in the ED. So there are 4 rhythms that can cause cardiac arrest, and hopefully you know them already, but just in case, they are ventricular fibrillation, or VFib, ventricular tachycardia, or VTAC, pulseless electrical activity, PEA, and ventricular asystole, I guess flatline. When it comes to defibrillation, we can hit VTAC or VFib with a shock. By the way, identify this one. Not going to tell you. You guys should know it. All right, it's VFib. So you can shock VTAC or VFib, but nothing's going to happen if we try to shock PEA or asystole. You can't shock a heart that has no electricity in it. We can, however, do compressions on all of these. And yeah, you absolutely should. So one of the most important things in the ED is to know who you're working with and know your role. In a true situation, in a true code situation, the best team members go exactly where they're needed. They know each other's jobs as well as their own. And sometimes you don't even have to talk to each other because each member kind of anticipates what the next move is and they execute it without hesitation. That's a strong ED team. Now, hopefully, during your career, you can have the opportunity to be a member of a team like that, and then you'll know exactly what I'm talking about. So, assessment here, you guys know. First, determine if your patient is truly unresponsive. Trust me, start doing chest compressions on someone who's still responsive, and they're going to let you know how much they don't like that. We want to check for breathing. You guys know how to do this. Look, listen, and feel. Check for that chest rise and fall. Listen for that breath, and get up close so you can feel it. We then want to make sure if they have a pulse or not. Do not check a radial pulse and start coding someone. You need to assess the carotid or the femoral. Carotid, you will feel a pulse there. One of the central pulses, basically. If that's missing, then yeah, start doing compressions. We also want to get them on the monitor really ASAP. It's the only way to truly determine what rhythm we're dealing with. And if we can deliver a shock, please do not forget that step, guys. So first things first with treatment. If there's no breathing and no pulse, we start compressions, right? As we're doing that, someone's going to secure the airway, usually with rapid sequence intubation. And don't worry, guys, there's going to be another lesson here on NRS&G all about RSI. Now, once the airway's secure, we got to breathe for them. And we can do that really with a BVM, a bag valve mask, or we can place the patient on a ventilator. We need to get that access, either with 2 large bore peripheral IV lines, an intraosseous line, or a central line. Now, nurses everywhere can insert peripheral lines, right? Every ED nurse knows how to throw in a line. IOs, or the intraosseous lines, are a little more restricted, so check with your facility. It is a recognized skill by the Emergency Nurses Association, but many facilities are not really letting ED nurses do it yet. Usually, the doc will try to insert a central line. If it's a teaching hospital, this is probably going to be the first-year guy. So if the rhythm is right, we want to defibrillate that VTAC or that VFib, give them a shock. Now, during all of this, once that access is obtained, we're pushing our meds. Many of it is timed, and it all follows the algorithms, the epi, the vasopressin, the amiodarone, and obviously fluids. It's very important during all this time that there's a recorder, someone writing down everything being done and keeping time for everything. So a big factor during CPR is trying to figure out why the heart's in a fatal dysrhythmia and how we can correct it. A very common mnemonic we like to use is H's and T's. These are all the things we try to address and correct if we can. So the H's. There's hypoxia. Well, we should be breathing for them. Hypovolemia, low fluids, give them fluids. Acidosis, the hydrogen ion acidosis, correct the pH, usually with some sodium bicarb. That might help. Hypothermia will get them warm. If you're lucky enough to have that blanket warmer, pull them out and throw them on. Maybe even use a bear hugger, something like that to get them warm. although the bear hugger might get in the way if you're doing chest compressions. And hypo or hyperkalemia, well, correct, whichever one they have. And then the T's or the toxins. Well, the T's, toxins can be poison or recreational drug overdoses. And I want you guys to remember, Narcan is your friend. It's also kind of a miracle drug, frankly. Tamponade is the heart being crushed. If you think it is, get your doc that pericardiocentesis needle and watch them work. Tension pneumo, let's do a needle decompression, which is, again, a nursing skill, or a chest tube, which is not a nursing skill. And thrombosis. If we think a clot is causing all the trouble, we might actually use the fibrinolytics here. That is a tough word, I tell you. That TPA. Usually, though, that is a last resort in a code like this. So we got to know our rhythms, guys. And if we can defibrillate them, the VTAC, the VFib, that you can shock. The others you can't. Perfusion is key. Get on those chest compressions. Do not stop unless a doc tells you to or you're doing a pulse check, usually that 2-minute pulse check. It would also help if you knew your ACLS pharmacology, know the drugs, and be able to anticipate which one's going to be next. Few key points here, guys. We have to recognize our rhythms. There's a big difference between PEA and sinus, and we need to know it. Always start compressions when there's no pulse. It's the best thing that's going to keep that blood flowing and get the oxygen to the brain. Prioritize, guys. Remember your steps. Follow your algorithms. Know which drugs, know your drugs. Know which drugs they are and when they need to be used. And also know your role. Are you the med nurse, the access nurse, the recorder? It helps not only know your role, but the role of your teammates as well. So thank you once again for joining us for this quick lesson, guys. Be sure to check out all of our emergency medicine lectures on nrsng.com. And as always, happy nursing.